Good evening, everyone. My name is Dr. Amar Swali from Dar es Salaam, Tanzania. I work at Sri Hindu Model Hospital as the consultant physician and nephrologist. And it is my honor this evening to introduce to you someone who is very eminent in the world of IgA nephropathy, and that is Dr. Suceena Alexander from the Christian Medical College. So she's the professor in the Department of Nephrology at the Christian Medical College in Vellore, Chennai, India. And she's also the additional vice principal of research at the same institute. And she's also an early career fellow in clinical and public health at the Wellcome UK DTB India Alliance as a PhD candidate. So I'd like to welcome Dr. Suceena Alexander to start off her presentation. Thank you so much, Dr. Suceena, for having us this evening.
Thank you, Dr. Amar, for those kind words of introduction. So good evening and greetings from Christian Medical College, Vellore. So this evening's Fireside chat will be on a very interesting topic to nephrologists as well as to general physicians. And it's titled Updates and Research Insights on IgA Nephropathy and Henoch-Schonlein Purpura. Now, before I proceed further, I will share a blueprint of how my presentation is going to be and my disclaimers. So my first few slides will be on history and the updates and not updates, because you should never forget your past as it's your best teacher. Every slide after that will be an updated knowledge of what we know now of IgA nephropathy. And it will be presented in the following format, which is epidemiology, pathogenesis, with specific references to genomics and cytokines. Then we'll dwell on clinical manifestations, diagnostics, initial risk assessment. We'll then go on to the treatment strategies and updated information on Henoch-Schonlein Purpura. Finally, I will share my own research perspectives as an early career researcher. So the star of this entire presentation, or what I would say is the IgA nephropathy HSP spectrum, is Dr. Jean Berger, who was a French pathologist. And he described IgA nephropathy in 1968. So he described IgA nephropathy in renal patients who had hematuria, and he saw IgA deposits in kidney biopsy, and that still remains the gold standard for the diagnosis of IgA even after so many decades. Now, coming to the epidemiology, most of the biopsy registries underestimate the true burden of IgA nephropathy. There are two problems to it. One is there can be IgA deposition in the kidney with no associated disease, and that's called the lanthannic IgA deposition. So if you look at autopsy registries or donor registries, then you may be seeing IgA deposition in up to 15% of the cohort with actually no IgA disease. The other caveat is the wide prevalence of subclinical disease where you are asymptomatic, but you may be having hematuria, microscopic hematuria or minimal proteinuria in your urine, which can be detected only if you do a universal screening, or if you are in countries where they do screening, where they do wide screening for school children or for college going students, like in countries like Japan and Korea. So a whole lot of these estimates depends on the biopsy practices that exist in various countries and regions. Overall, the population incidence of IgA is about 2.5 per 100,000. There is significant geographic variation that's been recognized from east to west, with the highest burden being in East and Pacific Asian countries, followed by Caucasians, and relatively rare in individuals of African ancestry. Now, this is beyond the variations that we see in biopsy practices. Still, even with all these variations, IgA nephropathy is the most common glomerulonephritis, primary glomerulonephritis in many different regions of the world, whether it's Asia, Europe, or US. Now, before we dwell in detail into the pathogenesis of IgA nephropathy, which is important because now every 5 years we are seeing a new hypothesis in the pathogenesis pathway. So before we delve in detail, we'll need to look closely at the structure of IgA, which is the immunoglobulin A. Now, as you can see, there are two IgA molecules here. There's one here and there's one below. Both of them are attached to each other. The IgA molecule has an antigen binding site like any other immunoglobulin and an Fc region. The distinguishing feature of IgA immunoglobulin is that it has a hinge, which is a series of proteins that connect the antigen binding region to the Fc region of the immunoglobulin. Of IgA nephropathy, this is one of the most important areas which we will look more deeply as to how it is important in the pathogenesis of IgA nephropathy. Now, IgA is a single molecule is monomeric. Now, when it joins to 2 to 4 IgA molecules, then it is called polymeric IgA. And the joining happens by connection of the end-to-end connection of the Fc portion by the joining chain. So this could join up to 4 molecules of IgA, making it polymeric IgA. You can also see as it transgresses the mucosal inserted into the IgA molecule. So the secretory protein is seen on molecules that are present on the mucosal surfaces, and it is usually not seen in the IgA that circulates in the blood. Okay, so now let's come to the pathogenesis as we know it of IgA nephropathy. One thing that we need to keep reminding ourselves is after all these, is the pathways that are proposed, is it so simplistic? Will it explain the variations that we see within ethnicities and within geographic regions? So is it a single disease or is it the same disease in different parts of the world? It's still a question that is lingering in the minds of many scientists. So the multi-hit hypothesis is a well-recognized hypothesis for IgA nephropathy, where simplistically saying there are 4 hits. The first hit is related to the molecular structure of the IgA, wherein there is a defect in the hinge region. As I mentioned before, there's a defect in the hinge region of the IgA molecule. The second hit will be the generation of autoantibodies. There are antibodies that recognize the hinge region as foreign. So you have, it's like an autoimmune disease. So you have autoantibodies that are formed against the hinge region. These autoantibodies can be IgA or IgG in nature. Once these autoantibodies bind to the hinge region of the defective IgA molecule, then comes the hit 3, which is a formation of immune complexes. And because these immune complexes are different from the normal immune complexes, as they have more, they are polymeric and they are higher molecular weight, they are more nephrotogenogenic. That is, they are more likely to be deposited in the kidney. So hit 3 is the deposition of these nephrotogenic immune complexes. And hit 4 is what happens after the deposition. That is the damage that happens to the glomeruli and the tubulointerstitial compartment following the deposition, which mostly is complement mediated. Now let's look a little bit more closely into the structure of the IgA, because that is the center point of pathogenesis. Now human IgA has two subclasses, IgA1 and IgA2. IgA1 has, again, it can exist as a single molecule, or it can combine and form polymeric IgA1. Usually what is seen in circulation is IgA1, and IgA2 is the most where what was in circulation, polymeric predominance is connected. Now this we need T, the S acid. Serine to IgA as a post-translational modification. So what it essentially means is you can have sugars that get attached to these serine, and is called enzymes involved in it. Isolated. And there are happens is that a collection of these amino acids, which will glycosylate amino acid. And this is lactose deficient. It's referred to as the patients. That is the reticular modification in the Golgi apparatus happens with different enzymes, and once it's glycosylated, it comes out of the Golgi apparatus, and here outside the Golgi apparatus is where the joining chain, that is a J chain, helps in combining the different IgA monomers into polymeric IgA. So that's what usually happens in a cell. Now in IgA nephropathy, what has been found is that there is defective expression of these glycosylation enzymes in the different layers of the Golgi apparatus. So it could be either a differential expression, or it could be that the enzymes are getting translocated from one layer to the other layer. So the addition of the different sugars are not in the right way it's supposed to be. So finally, the end product becomes a under-glycosylated IgA molecule that is released out of the cell. Now, the question still remains, if it is a monomeric IgA1 that predominates in the circulation, why do we see polymeric IgA1 predominantly in the glomerular deposition of IgA nephropathy? So let's have a closer look at what's happening. Now, this is the intestinal lumen. We have microbes in the mucosal surface that can cause mucosal infection. Now, these microbes, when it causes infection, it can lead to stimulation of the B cells, the naive B cells. They can get primed to fight off the infection. And there are mainly two pathways in which the B cells get primed. One is the T cell independent pathway, which is with the help of cytokines. So you have an IL-6 group of cytokines that act on these B cells and prime them and help them and induce the class switching of the B cells for the production of IgA molecule. The other well-recognized pathway for priming of the B cell is a T cell independent pathway, which again is with the help of B cell factors, which I'll called, there are different factors. They are called APRIL, BAF, and other pathways, which is basically they're T cell independent. And even they can induce B cell priming and class switch to produce IgA. So the IgA that is produced in the intestinal, in the mucosal surface is polymeric. Now, what has been seen as at present, as of now in IgA nephropathy is that there is a mistrafficking of the mucosal IgA producing B cells into the systemic circulation. So when the lymphocyte trafficking happens, there is a misappropriation, and some of the B cells that produce a mucosal type of IgA get mistrafficked into the systemic circulation. So then you get a mucosal type of galactose deficient IgA1 that is being produced in the circulation, and that leads to formation of, as I alluded to before, of the antibody, autoantibody against the hinge region, the immune complex formation, the deposition in the glomeruli, and the complement activation. So this is a present day hypothesis of IgA nephropathy. Apart from a poorly galactosylated IgA molecule, there is another hindrance to this molecule, because this is a structurally defective molecule, isn't it? So when it is a structurally defective molecule, even its clearance becomes defective. So usually the IgA is cleared in human hepatocytes. It's cleared by a receptor called asialoglycoprotein. Now this recognition is again hindered due to the structural difference in the IgA molecule that's produced. So apart from an increased production, a lower hepatic catabolism can also contribute to the increased levels that we see in IgA nephropathy, are nephrogenic. Now, before I go furthermore, a little bit more into the pathogenesis, which is a crux of the entire presentation, we will dwell a little bit on how genomics and genetics has helped drive the pathogenesis further. So genome-wide association studies, there are many studies that have taken place in multifactorial diseases like IgA nephropathy. And these studies in many, this involves multi-ethnic population and huge numbers, around 1,500 to 3,000 patients in each study. And these studies identified risk alleles that increased the susceptibility for IgA nephropathy in different populations. So when they looked at the risk alleles, they again found that East Asians or Pacific Asians had the most maximum number of risk alleles that made them susceptible to IgA nephropathy. And it was less common in the European and the Caucasian population, and probably rare in Africa. But we should, I should say here that the data from Africa is also sparse. Even within a US population, when they looked at the risk allele differences, they found that the risk allele was highest concentration was found in Asians, within the Asians residing in the US, followed by the whites, and then the African Americans. Now, another interesting feature is that when they looked at these risk alleles, it also explained probably how these risk alleles evolved over time was probably because of the local adaptation to pathogen diversity in these various populations, which is interesting. Now, when they tried to group all these risk alleles into the different pathways that were responsible for IgA nephropathy, there were 4 main pathways that were identified. So there was one pathway which was related to antigen processing and antigen presentation, that was the MHC region. The second main pathway was related to the complement system. The third pathway was related to the genes that affected the regulation of mucosal IgA production. And the fourth pathway was the genes that affected the innate immunity against pathogens. So this led to discovery of many potential therapeutic candidates that are being tested now. Many of them are in phase 2 and phase 3 trials. And many of them are related to the intestinal immune network. And it was almost like a direct result of these genomic studies that these candidate therapeutic targets were then identified to be tested in humans. So this is a snapshot of all the risk alleles that have been discovered in the various GWAS studies. I would like to dwell on two specific genetic locus that have been identified in these studies. One is on chromosome 22, and it's called the HOMAD locus. Now, this is related to the production of two cytokines, the leukemia inhibiting factor and the oncostatin. Now, to make it less complicated, we'll just call it the IL-6 related cytokines. So let's forget the other names and let's just call it the IL-6 related cytokines. Now, as I said, as I had shown in a picture before this, IL-6 can stimulate B cells to produce IgA molecules which are deficient in galactosylation in IgA nephropathy patients. So this is a T cell dependent pathway. And it was found that IgA1 producing cells from IgA patients, when they were stimulated by IL-6, it led to greater production of poorly galactosylated IgA molecules. The other gene that is of interest is the TNF superfamily gene, which encodes a protein called Addl and BAF. These are related proteins. Now, these are proteins that are involved in the stimulation of B cells in a T cell independent way, and they act on the BAF receptors on B cells and lead to the production and stimulation of IgA molecules in IgA nephropathy patients. And there's been a risk allele which has been identified in the Han Chinese population, which leads to an increased levels of serum IgA. Now, these two genes are of importance because when we talk about novel treatment or novel therapies in IgA nephropathy, these are contenders for treatment. Now, coming to clinical manifestations, so we have kind of finished the pathogenesis as we know now. Clinical manifestations are common phenotypes in IgA nephropathy. The most common phenotypes are the asymptomatic hematuria and the minimal proteinuria category, which is a subclinical disease, usually detected through screening programs. It has a favorable prognosis, but there is a subset that can go on to have persistent proteinuria and renal dysfunction. So everybody with this manifestation will require regular follow-up. The other common manifestation is chronic progressive kidney disease, and the 10-year survival can range anywhere between 57 to 91 depending on your geographic region and ethnicity, and also depends on the biopsy timing. The less frequent manifestation, but the classic manifestation that has been associated with IgA nephropathy is the synpharyngitic macroscopic hematuria. This is a classic clinical syndrome. And since it has a very dramatic presentation with macroscopic hematuria, the patients come to, the diagnosis is made much early in the course of IgA nephropathy. And so because it's made so early in the course of IgA nephropathy, the prognosis is the most favorable prognosis out of all the other manifestations. The other less frequent manifestation, again here, this is what is given in literature, but if you look, there are different ethnic variations, and even within what I will show later on may dispute this as less frequent manifestation, but nephrotic range proteinuria, there can be nephrotic range proteinuria, there can be a dual diagnosis of IgA nephropathy and minimal change disease. Now, how do we make this dual diagnosis? So you will have a patient who's presenting with nephrotic syndrome, like minimal change disease, But when you do the biopsy, you will see significant deposits of IgA in kidney biopsy. And when you follow it up with an electron microscopy, there will also be a significant podocyte effacement of the significant effacement of the food process. So it's either a two diagnosis which is happening, or we still don't know what the connection is between the two. The other less frequent manifestation is a crescentric type of IgA, and the recurrence of IgA, which is quite high in post-transplant. Now, diagnosis. How do we make a diagnosis of IgA nephropathy? Again, the diagnosis has to be by renal biopsy. We cannot make a clinical diagnosis because the presentations are very varied. There has to be a dominant or co-dominant staining with IgA by IF, immunohistology. And the distribution of the IgA staining is usually in the mesangium. There may or may not be capillary loop staining. It can be associated with IgG and IgM deposition, but the staining of IgG and IgM will never be higher than the staining of IgA. IgA will be the dominant or the co-dominant stain. There can be C3 deposition. If there is C1q, which denotes a classical complement pathway activation, then we definitely need to exclude other diseases like lupus nephritis. So this is a light microscopic view of mesangial proliferation, where we can see significant segmental mesangial proliferation and mesangial expansion in focal areas of the glomeruli. This is an IF staining, which again shows a mesangial uptake of the IgA staining. The capillary loops are not staining. The staining is absent from the capillary loops, and it's predominantly a mesangial uptake of IgA stain. This is the electron microscope view, where again you can see the GBM here, the capillary loop. The GBM is normal. There is no food process effacement. The capillary loop also, there's no capillary deficit seen. But when you come to the mesangium, there are significant electron dense deposits that are seen in the mesangium. Now, once you diagnose IgA nephropathy, the most valid classification as of date, the histological classification as of date, is the Oxford MEST-C classification. The Oxford group had brought out this classification in 2009. When it brought out the classification in 2009, it was called the MEST score. It did not have the C attached to it. It was only the MEST score, which had 4 categories. Basically, it looked at M, which is mesangial hypercellularity. It looked at endocapillary hypercellularity, which is a E. S, which is segmental glomerulosclerosis, and T, which is tubular atrophy or interstitial fibrosis. The crescent scoring, which is the C score, was added later on when there was a pooling of renal biopsy findings from different continents, and when they looked at the prognosis, how presence affected the renal prognosis and renal decline in renal function, the C score was further added. Now, the Oxford score has been validated in several studies, and one of the largest studies that validated the Oxford score in a multi-ethnic population was, I wouldn't say multi-ethnic, but in the European population, was the Valiga study, which looked at 1,000 odd patients. And they did confirm that especially the mesangial hypercellularity, which is the M1 score, the segmental sclerosis, which is the S1 score, and the tubular atrophy, which can be T1 or T2, depending on the percentage, was significantly associated with renal outcomes, especially in those who did not receive immunosuppression. They also found that there was a significant association of mesangial hypercellularity, which is M1, and endocapillary hypercellularity with subsequent increase in proteinuria in these patients. Later on, when the MEST-C score was formed, there was significant association found with crescents and higher risk progression, again, in those patients who were not immunosuppressed. So once we have diagnosed IgA according to the current classification system, we need to risk assess the patient for further management. So how do we clinically manage them? Now, for the risk assessment, there are a few clinical as well as histological parameters that will help. First of all, we need to rule out the secondary causes of IgA and make sure it's primary. So there are a whole lot of diseases and a whole lot of conditions that can cause secondary IgA deposition in the kidney. Now, these needs to be systematically ruled out. Some of the examples are already stated in the slide. After this, the risk of progression, the clinical parameters that help you to prognosticate the risk of progression. There are three main parameters that will help you: proteinuria, blood pressure, and the eGFR at baseline. Out of it, proteinuria is the strongest prognostic factor, and it does have a dose-dependent effect if the proteinuria is more than 1 gram per day. Now, among the pathology, there was a cohort study which found that when you add the histology score, that is a MEST score, and combine it with clinical parameters of eGFR, proteinuria, and blood pressure, and then use that composite score to predict renal outcome. So what they found was when you use a composite score to predict renal outcome, it had the same effect of using a clinical data after 2 years of following up a patient. So the baseline MES score combined with the other clinical parameters was so powerful that it allowed risk stratification at a much earlier time point than just using clinical data that was after 2 years of follow-up. Among biomarkers, there have been many biomarkers that have been studied in IgA, but there are no biomarkers that have been externally validated, or there are no biomarkers that is reproducible in a commercial assay that is available. And so it is still, it is still not ready for clinical, none of the biomarkers are ready for clinical application as of now. Now, the International IgA Nephropathy Network, which is the IIGANN, it's a collaborative network of researchers in IgA worldwide. So they came up with a risk calculator that uses all these baseline characteristics, the histology, the eGFR, the proteinuria, the blood pressure, and the treatment characteristics, whether they've been on ACEs or ARBs, whether they've been on immunosuppression. It is used to calculate the risk of progression of IgA over a period of up to 5 years. And this risk calculator is freely available for everybody on the net. And this is a link to it, which I have given in this slide. This is well validated in many studies in different ethnic population. Now, the treatment strategies. So essentially, as in all proteinuric kidney disease, conservative therapy comes first among the treatment strategies. Again, first among them is the renin-angiotensin system blockers, the RAS blockers. Specific to IgA, there was a study called Stop IgAN that was looking at, it was a randomized controlled trial which was looking at the usefulness of immunosuppression versus placebo. So there was a 6-month run-in period where the patients had to be on RAS blockers for 6 months. And the blood pressure was strictly optimized just on RAS blockers. And what happened was at the end of 6 months, they found that out of all the patients they had recruited into the study, 1/3 of them didn't even qualify to get randomized into the immunosuppressive or the placebo arm because their disease had remitted with just the use of RAS blockers. They fell into the inclusion criteria for the study, and that's why they were recruited. And then there was a 6-month run-in period where it was just intensive optimization with RAS blockers. And at the end of 6 months, almost 1/3 of the patients could not even proceed into the randomization because their disease had remitted. So RAS blocker is a cornerstone in the management of IgA nephropathy. And according the KDIGO guidelines, the BP goal is 130 if it is, and 125/75 if the proteinuria is more than 1 gram. Role of statins, again, the trials are not, the sample sizes are not very high here. There was one study which looked at fluvastatin versus placebo. It was on 21 patients, and there were no severe lesions in the biopsy, and they did not receive RAS blockers. The patients were randomized into fluvastatin versus placebo, and there was significant decrease in proteinuria in the fluvastatin arm. So statins can be given as part of the conservative therapy. Obesity is correlated with proteinuria. When when they looked at a cohort of 331 patients with IgA, about 45% of them had obesity. And people who were overweight or who were obese were more likely to be hypertensive. They had worse renal function and worse proteinuria. So weight reduction and smoking cessation is recommended as other conservative, other forms of management. Fish oil, again, the use of fish oil, KDIGO has a weak evidence base for this. It is, the grade is 2D. But since fish oil has been shown, especially to decrease cardiovascular mortality and decrease the systolic blood pressure, the triglyceride levels, the KDIGO does suggest using fish oil in IgA nephropathy if there is persistent proteinuria even after optimized supportive care. Coming to the role of corticosteroids. Now, corticosteroids can be divided into earlier era where there were smaller trials and the later era where there were larger trials. So in the earlier era where they used corticosteroids in smaller trials, many of them showed benefit. But there were major criticisms to these trials because most of these trials did not optimize patients on RAS blockers before randomizing them to corticosteroids or placebo. The other major criticism was that these were small sample size, so it was underpowered to detect any adverse event that could happen due to immunosuppression. So these trials did show, the smaller trials did show a legacy effect. So by legacy effect, it meant that even if you give a short course of steroids for 6 months, there was an effect of steroids that was sustained and led to the risk of progressive renal dysfunction. And when they pooled all these 9 trials and did a meta-analysis, even that showed a decrease in the risk of kidney failure, which was dose dependent, but of course associated with an increase in immunosuppression related adverse events. So next came the era of large randomized controlled trials with used corticosteroids. So the 2 large trials that changed the way you look at corticosteroids, one was the STOP IgAN study. It was a German study. This was designed to enroll 380 subjects. Again, as I said, this was a study that I alluded to before, where after a 6-month run-in period, only 1/3 did not qualify. So ultimately, the randomized patients were 162. And at the end of the study, they did show a reduction in proteinuria, but there was no significant reduction in the kidney function decline. And also there were more infections in the immunosuppression group, and there was one sepsis-related death. So this discouraged people from using corticosteroids in IgA nephropathy. The other trial was the testing trial. It was a global trial. Again, the target here was to enroll 1,300 subjects over 5 years. But what happened in reality was, after enrollment of 262 patients, there was an interim analysis which was done at 1.5 years. And after the interim analysis, the trial was prematurely terminated because though there was a significant reduction in renal outcome, there was a significant increase in serious infections, and there were two fatal, there were two deaths related to infection in the trial. So because of these increase in adverse event, the trial had to be prematurely terminated. Now the testing low dose trial is ongoing in different countries, but I would still say that the role of corticosteroids, the jury is still out, especially in populations where the progression of IgA is much more than what is seen usually in the literature. The other criticisms that we can say is that there was the Valiga study was a study that helped in the validation of the Oxford MES score that I had shown in my previous slide. Now, when they did a sub-study of it, it was a propensity matching based study. They found that patients who had proteinuria more than 3 grams showed a graded response to corticosteroids. In STOP IgA, and again, when you look closely, you realize that patients who had persistent proteinuria more than 3.5 grams were excluded from randomization, again limiting its generalizability. Testing trial also showed improvement in renal outcomes despite serious infections. So KDIGO, as of now, do suggest corticosteroids, short course in patients who have more than 3 grams of persistent proteinuria and eGFR, which is more than 50 ml per minute. Now, what about the role of corticosteroids in proteinuria less than 3, like for example, between 1 and 3, or eGFR less than 60 but more than 30? The answer is we don't know. The jury is still out. The two treatment regimens that the KDIGO has suggested, one is the IV methylpred alternating with oral steroid. The other regimen is a 6-month oral steroid where you give 2 months of full dose and then taper it over the next 4 months. Coming to other immunosuppressive therapy, mycophenolate trials have mixed results, but there could be a race-specific benefit in East Asian population where it's used maximally, but KDIGO does not recommend it as of now. Combined therapy with other immunosuppression like cyclophosphamide or AZA is usually reserved for very severe disease or crescentic disease. Rituximab has not found a role in IgA nephropathy as of now. Tonsillectomy remains very controversial. There are Japanese studies that have shown a benefit in the reduction in proteinuria, but again, the study has not maximally optimized conservative supportive therapy before performing the tonsillectomy. And there are European studies which have not shown any benefit. So it may be considered in patients who have recurrent tonsillitis. The other novel agents that have been that are being used now, there are trials ongoing with all these agents. One is an oral budesonide, which is a modified formulation. This is a steroid which is supposed to be targeting the distal ileum and the proximal large intestine. And it has a high first pass metabolism. So theoretically, it is supposed to reduce the systemic effects of steroid. There was a phase 2 trial which showed that there was significant reduction of proteinuria after 9 months of treatment. But again, about 22% of the patients withdrew from the study because of steroid-related side effects. So though theoretically, there is an assumption that systemic absorption is less, in phase 2 study, there was significant adverse events noted for this drug, and the phase 3 trial is still ongoing. A purified form of ACTH is another drug that is being tried in many proteinuric illnesses, including IgA. Bortezomib is a proteasome inhibitor which will help in inhibiting the IgA production from the B cells. Fostamatinib is an oral spleen tyrosine kinase inhibitor, which is a downstream pathway inhibitor. Now, I had mentioned to you about two cytokines, which are Addl and BAF, that are T cell, that help in the T cell independent stimulation of B cells. Now, atacicept is a monoclonal antibody that binds to the Addl and BAF receptors in B cells and prevents B cell stimulation. And this is a very promising therapy in IgA nephropathy, and there are at least 2 phase 3 trials which I know are ongoing with this drug. There are complement inhibitors that are being studied, which helps in inhibiting the glomerular injury. So this is just the same picture which shows the different areas where these drugs are targeted. There's a targeted release budesonide, which targets the mucosa. There's BAF and Addl inhibitors, which target the B cell and inhibit the stimulation of B cells. There's hydroxychloroquine, which will inhibit the immune recognition of the microbes by the B cells. There are complement inhibitors that can act at the level of the renal injury. Then there are proteasome inhibitors that can inhibit IgA production from B cells, and corticosteroids and spleen tyrosine kinase inhibitors downstream of the pathway. 2 atypical forms of IgA nephropathy that we see. One is minimal change disease with mesangial IgA deposits. Again, here the consensus recommendation is to treat the patient like minimal change disease because they are very steroid responsive. The other form is acute kidney injury associated with macroscopic hematuria. Again, there can be 2 differentials for it. One is due to ATM or intratubular erythrocyte CAS as a result of macroscopic hematuria, where you need only supportive care. And the other differential for this is a more rare or uncommon form of crescentric IgA nephropathy, where you will need to treat you. Now, coming to Henoch-Schonlein Purpura, again, this name has been replaced. It was formerly called as HSP. The new name is IgA vasculitis. So I'll not be referring to it as HSP anymore. I'll be referring to it as IgA vasculitis from here on. So the definition of IgA vasculitis, it is a small vessel vasculitis. It is clinically characterized by non-thrombocytopenic purpuric rash, non-deforming arthritis, GI involvement, and nephritis. So it is a multi-organ involvement, not like IgA nephropathy, which is restricted to the kidneys. It's more common in the Asian population. 90% of them happens in children who are less than 10 years of age. It can happen in adults. Adults tend to have less abdominal pain and more joint involvement. Kidney involvement happens in about 30 to 50% of patients, and usually the kidney involvement is benign. It's usually microscopic hematuria. But as the age increases, you can have other forms of nephritis as part of kidney involvement. And the prognosis is usually favorable. There is very little progression to end-stage kidney disease. The pathophysiology is very related to IgAN. So you do have elevated systemic IgA levels and IgA immune complexes. So many people do believe that this is spectrum of the same disease, and that's why the name change from Henoch-Schonlein Purpura to IgA vasculitis. There is also elevated abnormal glycosylation of the IgA1 molecule, which is there in IgA vasculitis, which has been detected in IgA vasculitis. This is a picture of the skin changes that you can see. It's a palpable purpura and usually starts in the lower limbs. 70 to 90% may have a lower joint oligoarticular involvement. GI involvement is mostly colicky abdominal pain. You may have acute GI bleeding. Renal involvement is the most serious of all the other organs because this is the one that is linked to long-term morbidity and mortality. There can be testicular inflammation or very rarely CNS involvement. Now, the EULAR, which is the European League for rheumatism has defined the criteria for IgA vasculitis. This has very high sensitivity and very high specificity for distinguishing IgA vasculitis from other forms of vasculitis. Now, the mandatory criteria for this is purpura with a lower limb predominance. And then out of the four other criteria, you need to satisfy at least one. Two of them are related to kidney. One is histology, which can have a proliferative glomerulonephritis or the finding of proteinuria or hematuria. Now, just like the MEST classification, the Oxford MEST classification you have for IgA nephropathy, the International Study of Kidney Disease in Children have proposed a grading for classification of IgA vasculitis, which is grade 1 to 6. And it's based on the presence or absence of mesangial proliferation, presence or absence of sclerosis, and crescents. The treatment trial of concentric Right, so we come to the last section of our talk, which is research perspectives. Again, my research is called essential experiments. So I'll take you to my journey. It's still very early in my college perspective. So my transition from a clinician to clinician, usually people say bench to bedside, but for me, it was bedside to bench. What I would say as an essential, some of the essential ingredients for a clinician to have some kind of clinical research is to identify senior researchers or clinicians in your own department or in other institutes who will serve as mentors and who will guide, who will review, who will critique you, and who will take you through the various process of the applications. You need to identify a problem that is unanswered in your population, and it needs to be a problem. So for us, IgA nephropathy, if you look, it is probably the most researched topic in the world when it comes to glomerulonephritis. But still, when you look at South Asia, we hardly had any research apart from papers on retrospective biopsy registries. We did not have significant research in IgA nephropathy coming from our region. But when we looked at our retrospective biopsy data, we found that what we are reading in the textbooks are not what we are finding in our population. So there was a gap between what is being taught to us and what we are seeing. So that became an unanswered question or a problem for us. Then the other essential ingredient for any research is any clinical research is access to patients and biosamples, funding definitely, and need to establish a lot of collaborations with your colleagues and with other people within and without out of the institution. The most important need for a clinical cohort is a well-characterized phenotype. So if you're planning to establish a clinical cohort of, you say, FSGS or minimal change or any other disease, the most important thing is to make sure that your diagnosis and your phenotype is well characterized at baseline, and make sure that the follow-up of that cohort is good. So if you have a good follow-up of a well-characterized cohort, then that will be the greatest strength. And along with it will come the biosample repository. And it usually takes about 5 years to build a good longitudinal cohort. Then you can identify the characteristics that are different in your cohort. Now, having said this, I will just dwell on a few differences that we found in our own population. So this is Gray's IgA nephropathy cohort, which we established. This was, the cohort started in 2015. Now I think most of the patients have completed about 4 years of follow-up. So we had a phenotypic characterization, we had histopathological and clinical correlations, and then risk assessment at baseline. Our CMC is situated at the southern part of India, and most of our patients come from the southern, the east, central, and the northeastern part of the country. When we looked at, when we stratified patients according to proteinuria and GFR, we were very clearly able to see the phenotypic differences that were there in our population with regards to proteinuria and eGFR at baseline compared to, so what I said as a less frequent presentation, that nephritic presentation, when it comes to our population, I wouldn't say it is less frequent because it becomes a very frequent presentation for our population. Now, when we looked, so there were many people who said this could be lead time bias in biopsies. But when we looked at the time to biopsy, the average median time was about 8 months. So though lead time bias could be one of the potential reasons, but it could not explain the entire phenomenon that we are seeing here. The other interesting fact was that when we correlated the MES score with the clinical parameters like mean arterial pressure, 24-hour urine protein, and eGFR, we found that even in higher GFRs, there was significant amount of chronic histological damage, which was surprising. The risk stratification was done using 2 equations, which Addl has not been validated in our ethnicity. One is a Tanaka equation, which is validated in the Japanese population, and Barber is a IgA risk stratification that I alluded to before, which was developed by the International IgA Nephropathy Network. And both risk scoring showed a higher, showed a high risk population with a high risk of progression in our cohort. They were subgrouped based on our center's policy for treatment, because we do give immunosuppression if there is significant proteinuria or eGFR decline, because we do see a higher risk of progression. And these are unpublished data, but there's been, at the end of 3 years, when we looked at the outcomes, we found that at least 40% of them, about 37% of them reached a composite outcome. The composite outcome what was defined as 50% decline in eGFR, or eGFR less than 15 ml per minute, or need for renal replacement therapy, or death. So there was, it was a significant, significantly high progression. I will skip these slides for want of time. This was another, these are all preliminary unpublished results. So this was, we have looked at the level of galactose, serum galactose deficient IgA1 levels in our patients, and we couldn't really find any diagnostic, any significant difference of GDA1 levels in our population versus healthy controls. Though it did, though it was higher in patients with higher chronicity and higher risk group, when it came to actual outcome at 3 years, there was no significant correlation. And when we looked at the longitudinal levels, there was a decrease of the Gd-IgA1 levels at 1 year, because this was a cohort that got the immunosuppression. But surprisingly, the same decline in the serum Gd-IgA1 levels also paralleled the decline in serum immunoglobulin A levels. And yeah, so these are some of the preliminary results, and hopefully this will lead to many more experiments and many more learning for us from now on. Thank you.
Thank you very much, Dr. Suceena. That was actually a masterclass on IgA nephropathy and IgA vasculitis. We have some comments in the chat box. However, I would like to invite the audience to interact with Dr. Suceena directly before we address those in the chat box. So the floor is open.
So should I take the questions one by one now?
Dr. Suceena, can I just, I'm Ridendra Bhima, I'm a pediatrician, but I'm not, I'm in Durban, South Africa. So right at the tip of Africa. Nice meeting you. And thank you for that excellent presentation. That was really wonderful. I really appreciate that. So I'm not an expert on IgA nephropathy, but I'm going to talk about IgA vasculitis, okay? Because I don't see adults, okay? But I must say that when we look at IgA vasculitis in our population, and although you said that it's much more common in the Asian population as opposed to other racial groups, for the few patients that we have seen a more or less equal spread in our Black populations as opposed to, but that may be because of the population distribution. I mean, we have over 70% of our population, 70 to 80% being Black patients, and the rest made up of either Indian or mixed race or Caucasians. So I must say that difference doesn't bear out in our cohort of patients. But my question to you is that, looking at the scoring system, etc., that used, I must say that where we in pediatrics use proteinuria as our main indicator for the degree of immunosuppression that we're going to give. So if we find that we have more than 1 gram proteinuria per 24 hours, so what we call nephrotic range proteinuria, we will definitely pulse these patients with methylprednisolone and then give them steroids, okay? Other than that, the validation system in the pediatric population, I don't know if that is, I haven't seen it in the literature yet using the MESC score. Have you come across that?
So are you talking about IgA vasculitis or are you talking about IgA nephropathy?
I am talking about, well, the patients who develop the IgA vasculitis, okay, when we biopsy them, okay?
IgA vasculitis?
Vasculitis, yeah.
Oh, IgA vasculitis, the MESC score.
I haven't come across any similar scoring system for that.
No. But there are pediatric populations where IgA nephropathy, where the score have been looked at. But in IgA vasculitis, there are a few papers, but I don't know about the pediatric population. I'm not aware. But it's even in the adults, the IgA vasculitis correlation with MES score is very few papers.
Yeah.
It's mostly with IgA nephropathy.
Yeah. I thought as much. So we just use that mainly for our classifications and treatment. See. All right, thank you.
Thank you.
Thank you, Professor Bhima. So, Dr. Suceena, we can probably start with the chat box. And the first question is from Charles Omondi. And he is requesting for a comment on the possible role of belimumab, since BAF has a role in the pathogenesis of IgA nephropathy.
So, belimumab has been studied extensively in lupus nephritis. I don't think there's been a randomized controlled trial of belimumab in IgA, mainly because there are other molecules that are looking at this specific pathway. As I mentioned, there is one molecule which is looking at anti-APRIL monoclonal antibody, which again, APRIL receptors are BAF and TACI receptors, which are on the surface of B cells. And there is another molecule which is atacicept, which inhibits APRIL as well as BAF. So it's inhibitor of both APRIL and BAF, atacicept, which inhibits their binding with the ligand on the B cells. So these are the two molecules that have been that are being looked at in IgA nephropathy. So I'm not aware of belimumab as in any phase 3 or RCT trials. If there's anybody else who knows about it, welcome to.
Thank you.
Just a question, Suceena. Thank you very much for that wonderful presentation. It was very comprehensive and excellent, and yet very much in detail. It was wonderful. Thank you so much, especially the pathogenesis and the whole of the multi-hit criteria and everything was so clear, and the polymeric, how a polymeric structure is important. In primary and secondary IgA, are the IgA molecules both the same? Are they polymeric as well in secondary as well as compared to primary? I mean, like in primary?
So there are certain diseases where they have found polymeric IgA in detail about the IgA1 structure in secondary causes of IgA. It's something that I will have to look up.
Okay, and the second question, one more thing. It's very interesting in your data. You show that the composite outcomes definitely are much lower at 3 years, despite the histology being good. How do you account for that, decline in GFR, proteinuria, and the hypertension that comes on in these patients, and still the histology being very good? Is there something to do with the interstitial changes only happening there, or how do you explain that? And they're much worse off as compared to the general IgA that is generally reported.
No, the histology, what I said was probably I was misunderstood. So what I said about histology in this clinical correlation was that even at higher GFRs, that is at GFRs more than 50 and more than 40 ml per minute.
So I was not clear with what I heard.
We could see more chronic histology. So there were more T1 and T2 lesions, even when the eGFR was higher. So we do expect, even at a higher eGFR.
EGFR, okay, fine.
And the composite outcome in our population was high. We had, actually the data is being reviewed now. It's the manuscript is under review. At 3 years, when we looked at the outcome, about 37% of the patients had progressed. That is a high progression. High rate of
Yes. Yeah. So that means you all have a lot of interstitial changes in your population, right?
Yeah, looks like we also had a significant amount of our population having the S1 lesion. So that also was higher than what's reported. S1 lesion is not really, it's usually in the 30 to 40% range in the other world literature. But in our cohort, we could see up to 70 to 80% of them having an S1 lesion.
Okay, great. Hematuria, did you look at the hematuria and those patients in whom the hematuria has come down? Is there a change in the GFR, improvement in the GFR? Is there any relationship like that that you find in your population?
Yeah, so hematuria for most of our patients, and no association of hematuria with any outcomes. But there was significant association for decrease with time to composite. If you achieve less than 1 gram per day of proteinuria within 6 months to 1 year, then the rate of decline of eGFR is much lesser. Thank you.
Dr. Rogajo has raised his hand. Dr. Rogajo, you're welcome. While we wait for him, there's another comment, Dr. Suceena. It's again from Charles Omondi, and he's commented that rituximab is used in IgA vasculitis, but not in IgA nephropathy. Is there a comment for that?
So rituximab has been looked at, but in trials, again, the sample sizes were small. But in the trials where rituximab was looked at, because obviously it's a B cell disease and it is a B producing disease, so you would expect rituximab to have an effect. But unfortunately, in those trials, there was no significant difference noted in outcome.
Thank you very much.
Hello, do you hear me?
Yes, Dr. Rogajo, welcome. Welcome.
Okay, thank you so much. Suceena, thank you so much for a very comprehensive lecture on IgA nephropathy and the IgA vasculitis. My name is Dr. Pascal Rogajo. You also know me as Joseph.
Yes.
It is so nice to see you, and you don't seem to be aging a bit. So my question is, my question is, the kidney biopsying here is still budding, and we are most of the time resource restricted, and that makes us just predominantly rely on light microscopy. So immunofluorescence and electron microscopy is still not developed as much here.
Okay.
As you can expect, we get from the nephropathologist most of the time is change disease, which probably would have translated to do immunofluorescence. So my short question would be, how much percentage of minimal change, what is referred as minimal change disease would probably be IgA nephropathy if we had immunofluorescence established?
So I had said about 15% in the, this is quoting the different studies. So it varies from 3 to 15%, the dual diagnosis of IgA nephropathy and MCD. But then I would say that you, since the management is dependent on the diagnosis of MCD and not on the diagnosis of IgA, even if you don't have immunofluorescence and but you are sure of your diagnosis of MCD, that would be enough for the clinical management of the patient.
I see. Thank you, Suceena. Thank you so much.
Back to the chat box again, and we have another question from Dr. Mazhar Amirali from Tanzania, and he would like to know your opinion on the use of SGLT2 inhibitors in the treatment of IgA nephropathy.
Yeah, so SGLT2 definitely, it's an upcoming treatment. That DAPA-CKD study, which had a huge subgroup of IgA nephropathy patients who received SGLT2 inhibitor. And there was a recent editorial, I forget which journal, but where they had discussed in detail about the role of SGLT2 inhibitors in IgA nephropathy, and I'm sure we will see more of it in the near future.
Another question from Michael Waldemariam, and he asks, why are there different staging and scoring systems for IgA nephropathy and IgA vasculitis?
Difficult to answer. Basically, I would probably say that IgA nephropathy is an adult disease and IgA vasculitis is usually seen in children. So IgA nephropathy was, the scoring was initially developed for IgA nephropathy, and so it was not even seen as the same disease, I would say. It's only when they started looking at the pathogenesis and when they looked, when they found that there was poorly galactosylated IgA1, and when they started looking into HSP and the role of poorly galactosylated IgA1, did even the name change from HSP to IgA vasculitis. So it was later on in the research that they found this connection in the pathophysiology between IgA nephropathy and IgA vasculitis. So that's when people thought of these two diseases as being a spectrum, two diseases of the common spectrum. So probably that must have led to the different staging and scoring. I'm not sure why, also because these two diseases are seen in two different populations. Mostly, one is mostly in children, the other is mostly in adults. I don't know whether that is the reason for the different staging. Probably.
And one last question from the chat box. What is your comment on renal transplant in patients with CKD secondary to IgA nephropathy on donor selection?
So post-transplant, though the recurrence of IgA nephropathy is common, it does not affect the graft function so as to discourage transplant. So transplant can proceed even if the recipient has IgA nephropathy. The donor selection, again, there is no real evidence that you need to avoid related donors for patients who have IgA nephropathy. As I said, even if there's a recurrence of IgA nephropathy post-transplant, its effect on graft outcome is negligible.
I would invite more comments from the floor before I hand over to Dr. Lloyd to close the session. Dr. Lloyd, are you there?
No more comments or questions. I think we will come to an end today for the end to the session. Dr. Suceena, I think that was a wonderful presentation, a wonderful session indeed that we've had. Extremely grateful to you to come on board and give us this outstanding update on IgA nephropathy and IgA vasculitis and answering so much of our questions. It was very interesting that that you're doing so much work, and as an example that you set to the rest of the world, that from the developing countries to high quality research can be done. Thank you once again for this wonderful presentation and sharing your knowledge with us on IgA nephropathy. Thank you. We hope that we would have you more frequently here in the coming time, in the months from now.
Thank you. My pleasure. It was an honor for me, and thank you for the invitation, Dr. Lloyd. And